and a little bit about obesity medicine because of the association between obesity and a multitude of cancers, especially for what I do, colorectal cancer. And so, you know, one of the misnomers out there is that in this society, American society, we look at obesity and obese people as if it's a choice. We look at it as if, meaning, you know, that if you're obese, you did something wrong. You're lazy, you have no self-control, but that's not true at all. And I don't know if Dr. V can chime in.
She's just going to rejoin.
So she's going to rejoin. And Dr. V, can you hear me?
I can hear you.
All right. So I already did your amazing introduction, your long signature page, all your titles and everything. And I left off by saying that in American society, we look at obesity as if it's a choice. That if you're obese, you're lazy, you have no self-control. This is still the group of people that is made fun of on television. And that's not true, is it?
No, it's not true at all. It's been a complete misperception in our society. So for so many years, honestly, decades, it's been perceived that individuals with obesity, that they lack willpower. And that's why they are unable to lose the weight and keep it off. And we know that's not true. There's tons of literature, there's tons of research out there showing that this is actually a chronic disease. There's real biology behind this, which makes it so hard for people to lose weight and keep it off.
Right. So it's not just a choice. You know, even you saying this, you know, people, even some of my friends, when I try to educate them, like you've educated me, say, well, no, it's still 60% willpower. So if you had to break it down for everybody, percentage wise, what percent is your fault, which is a misnomer, period, because it's never your fault, but you know what I mean.
Yeah, I know what you mean. So, you know, there's always going to be variables that play into our weight that are within our control. So what we like to say in the obesity medicine field is that there's two types of variables playing into our weight. There's controllable variables and uncontrollable variables. Controllable variables are the ones you're referring to, Zuri. They're the ones that are our diet, our exercise, our sleep hygiene, how we control our stress. But then there's other variables that are not in our control. How about our genetics? How about what mom was doing when we were in the womb and we had no control over? How about when we were a child, the area that we grew up in, the pollution around us, the chemicals in our food? That is not within our control. So there's so many things, honestly, that pertain to weight that are not in our control that we don't really acknowledge as a society. So it's very invalidating to patients when they hear from a provider, you know what, just work harder, eat less, work out more, you'll take care of it. That's not true. If that were true, why is 70% of people with overweight and obesity in this country? It's not because 70% of people are lacking willpower.
Right. It's our, as you like to say, and it's true, our epigenetics.
Yes.
It's our environment plus our genetics. And so, you know, I'm going to tell you what everybody asks me, and you know what I'm about to ask you, okay? And, you know, we have these new amazing medications out here, which I get inundated with requests all the time, and they're called GLP-1 agonists. Now, I tell people that the way they work is trifold, meaning that it decreases the pleasure you get from food in your brain. It slows down your GI tract, you feel fuller, and it stabilizes insulin levels. Is that true? Is that accurate?
That is accurate. And actually, we're finding out that this class of drugs is really incredible, that it does even more than that. We know that it can actually help with improving heart health and reduce inflammation in the endothelium, which is the lining of our vascular system. We know that it can actually improve our kidneys. We know that it can do so much more than just helping with weight. So there's direct ways it helps with those other organ systems, and there's indirect ways because, of course, losing weight can help those other medical conditions.
That's fantastic. And now we're going to get into the rapid fire, okay?
Okay, I'm ready. Let's do this.
What is the difference? And I want everybody out here, take some notes, okay? Because this is what we get all the time. There's Ozempic, there's Saxenda, there's Wegovy, there's Mounjaro. What's the difference?
Yeah, so these are all very, very similar in that they fall in a class of medications except for Mounjaro, but all of those fall in one class of medications called GLP-1s that you've been talking about. And GLP-1s are essentially a gut hormone. All of us have this gut hormone, but now we're making it work better. And by taking this medication, it can help with all of the different things we talked about. It helps improve your weight, helps improve different organ systems, helps improve insulin sensitivity. So with these medications, what's happened is over the last decade, they've gotten better and better and better with how much weight they can help you lose. The first medication in this drug class that got approved was back in 2014. We're talking almost 10 years ago. And that was Saxenda, which is also known as liraglutide, 3.0 milligrams. So that medication was really great, but it only helped on average help people lose about 8% of their body weight.
Okay.
And that is a good amount. That is clinically significant. That means that it's going to improve your other organ systems in a way that is going to be meaningful. At the same time, we wanted to help people lose more weight. So we've been very, very lucky that in this last year, a newer drug got approved, FDA approved for obesity and weight management. And that one is Wegovy. And that one is semaglutide, 2.4 milligrams. That is basically the sister to Ozempic. Ozempic has been around for a decade. That's been doing its thing for patients with diabetes. And they said, you know what, let's make that one a little bit better and help people lose a little bit more weight. And that's what they found with the research trials.
So it's not exactly the same. So Ozempic is not exactly the same as Wegovy.
Yeah, so they're basically in the same drug class, but there's a little bit difference with their, basically the hormone of how it works. So it works a little bit better. It kind of locks and keys better to help people lose actually closer with, for example, Wegovy, people lose closer to 15% of their body weight in 6 to 12 months versus Saxenda, I mentioned, helps people lose 8% of their body weight. So now we're talking double.
That's amazing.
Yeah.
That's amazing. And now tell me about this Mounjaro, because that's another one that everybody's been. Yes.
Okay, so Mounjaro is actually FDA approved for type 2 diabetes. And that one is a slightly different class than what we see with, GLP-1s. It's a GLP-1, and it's a GIP. GIP is another gut hormone. So now we've got two gut hormones in one drug. What do you think that means? That means better weight loss. And it also means that it is just more effective at helping people feel fuller and really take down those cravings, help people to be able to regulate their appetite. So Mounjaro helps people to lose on average 20% of their body weight.
Wow. Now, the hard thing is, and I know people are going to ask is, and tell me if I'm wrong, is that Ozempic and Mounjaro are both currently only indicated, meaning that the insurance typically is only indicated for diabetes. Is that correct? Not actual weight loss yet, but Wegovy is indicated for weight loss, and they're working on trying to get Mounjaro indicated actually for weight loss.
That's correct. That's totally correct. And, I want to also dispel something that goes on, I think, oftentimes when we're talking about weight medications, is that there's a lot of talk about off-label use.
Right.
Is that right? Should we be doing that? Well, we've been doing that. You and I know that as doctors. We've been doing that for Tylenol, to ibuprofen, to any of these regular drugs we see day to day at Walgreens and CVS. We prescribe those off-label all the time. Then you start doing off-labels with weight medications and people get, kind of their feathers all fluffed because there's a stigma around these medications. People are hesitant to want to use these medications because they still are thinking that old way that we talked about earlier, that this is about willpower, and it's not. It needs treatment.
Right. It's not a failure to take these medicines. It's not a failure of some people to need weight loss surgery, but people look at it like it is.
100%.
Now, something that scares me now, though, is that because of some of the prices of these medications, people will call me and say, hey, I know a practitioner who is compounding this, or they get, Ozempic and draw it out of the tube and then give it to patients. And for that scares me. And that's not what you were just talking about. You're talking about actual medications that are we can prescribe. But I tell them it's not safe for people to just go somewhere where they're making it, mom and pop.
You got it. I agree, Zuri. I tell all my patients, I do not recommend the compounded form. We do not know what's in that. It is not regulated. So for those who are listening, please avoid that type of medication. See your healthcare provider and get the FDA approved medication if you're indicated to get something like that for you.
All right. Excellent. Now, we're going to talk about some side effects, okay? As a GI, as a colorectal surgeon, I do a lot of GI also. I hear about this constipation that can happen with these medications. And the way I treat patients is, as they go up higher on the dose, I make sure they take something mild like Miralax. I'm not sponsored by
Oh,
Miralax. Okay, I'm just telling you what I
yes.
do. Okay, but
No.
I have them take Miralax every single night, period, because I've had patients with constipation, and that makes sense because it slows down the GI tract. But now I have some patients with diarrhea, and why would diarrhea happen if your GI tract slows down?
Yeah, that's a good point. So what we see is that patients may experience diarrhea if, for example, at baseline, already going into the medication, maybe they already were experiencing looser stool, and
Got it.
maybe some of it is diet related, right? So when people are consuming high fat, high sugar foods, when you start these drugs and your GI tract slows down and you've got maybe a high fat food or a high sugar food just sitting in your colon,
Yes,
that is going to actually then draw in, right, the water and make the
exactly.
body want to flush that
Right.
out. So there you are with the diarrhea. So we really advise that when patients are dealing with diarrhea on this medication to take a close look at the diet and ensure that there aren't really high fat, high sugar, high processed foods, because that's going to trigger it.
Okay.
The other thing is that for patients, sometimes they're on other medications that could be a side effect with the diarrhea, and therefore we're kind of having to work against that. So we see some of that issue too. So that may mean having to work with multiple doctors and working with your whole care team. So we want patients to be empowered and talking with all their healthcare professionals to
Right.
make sure that they're doing well on this medication. I feel like I hear a lot from patients, oh, the only reason I lose weight is because I'm having diarrhea and I'm vomiting.
Right.
No, that is
No.
not why you lose weight on this drug. It is changing your physiology. It is changing the way your body works on a biological cellular level to help it change the set point of where your body wants to be at 230 and you've never been able to budget. Now you're down to 190. It's not because you've been vomiting. We do not want you actively
Right.
vomiting. We do not want you with active diarrhea. We want you to feel healthy, good quality of life, lose weight, and improve those medical conditions.
Excellent. Now, something else that I hear all the time in the questions I get, because I tell people, if you have a history of medullary thyroid cancer, which is very rare, or acute pancreatitis, then this medicine is contraindicated. Now, people ask me, well, wow, it's going to give me thyroid cancer.
Yep. Okay, this is a good one because there's definitely been more media attention around this.
Yes.
So I think you make the best point about it, Suri. It really is that the medication, it's very, very low risk for it to cause any type of issues for the thyroid. We know that from preclinical trials, what does that mean? That means not in humans. That means in rats, in mice, that they've done studies and found that this drug, if you were to use this class of medication, GLP-1s or GLP-GIP, right, the Manjaro,
Right.
those medications, if used in rat and mice, and they had a history of medullary thyroid cancer, that it could worsen this type of cancer. That's why we always screen our patients like you do and say, hey, do you have a history? Does your family have a history of specifically this type of cancer? Because it has not been shown prospectively, meaning in the future, to cause patients or humans to have thyroid cancer. We know from actually one study that came out about 6 months to about 12 months ago that was looking backwards, retrospectively, and said, what happens with patients who have been on these medications compared to ones who haven't? And they looked at this big hospital database and said, what is the risk of thyroid cancer in the general public compared to what is the risk of thyroid cancer with patients who are on these drugs? They found it was 1% risk in the general public and about a 2% risk with people on these drugs.
Got it.
So that is a very, very, very minute difference, and it is not reason for us to not prescribe these drugs. I think people, again, are getting their feathers all fluffed, you know, and we try to hyper focus on things to find errors with these because people want to keep going back to those biased opinions that we don't need these. And that's not the case. There's so many benefits that we've talked about with these drugs that they should be highly considered unless, of course, you have these unique histories of medullary thyroid cancer.
Great. What about if I have gallstones?
Yeah, good one. So gallstone is a relative contraindication, meaning you may want to have some hesitation, some conversation, pros and cons of starting the medication. Maybe we'll be more judicious or careful with how we'll prescribe it and be very slow with the increasing of the dosing. But that doesn't mean we can't prescribe it. It actually could improve overall your liver and biliary tree, or the tree, or the kind of passages to your liver. It could actually improve that health overall by weight loss. So we may want to still consider that medication. So that's a conversation between a patient and a provider to decide.
Great, great. I'm going to ask you a serious question, and then we're going to talk about some of these silly Ozempic face and all that crap. Okay? We're going to talk about, and I say crap as a colorectal surgeon, so I know what crap is.
Fair.
So, am I going to have to be on this medication forever? Now, we've talked about this, and I like to say that no matter how big I am, when I weighed 40 pounds more than what I weighed, I was on blood pressure medicine.
Yep.
I am 40 pounds less. I still am on blood pressure medicine.
Yep.
Because genetically, I'm going to be on blood pressure medicine. I'm going to have to take that my entire life.
Yes.
Now, people say, well, if I start this medicine, do I have to take it forever?
Yep. So in short, yes. Because we know that the biological pressures, that the body wants to go back to the highest weight. So you 40 pounds ago, that's where your body wants to be. And it will fight you and do everything.
70 pounds, actually. It wants to be 70 pounds more. Okay. That's what it really wants to be. I just have to.
Okay, so it wants to be 70 pounds plus from where you're at right now. And because of that, we know from the research, there's actually studies that have shown that these pressures the body's doing. And what do I mean by these pressures? That means that your body actually, in response to you eating healthy, exercising, and taking this medication, will actually make your metabolism drop. It will actually try to make your hunger hormones respond by getting higher, trying to fight against the working of the drug because it wants you to be 70 pounds plus. It will actually do that the rest of your life. So without that medication to suppress those pressures, to keep those pressures down, you will continue to have this lifelong battle of getting the weight off. That is the beauty of these drugs, is it calms these pressures to allow your healthy lifestyle to work and keep you at -70.
Okay, so now somebody like you who has been, pretty thin their whole life. Now, if you took that medication, right, it doesn't actually make you gain more weight ultimately because your epigenetics, for whatever reason, you are naturally thin. So if you took the medication because you gained 5 pounds, going on a cruise, and you went back to what you are now, that in and of itself won't, or will it make you ultimately need the medication to stay back at your normal weight?
Yeah. So the pressures that I'm referring to, those pressures are not ones that we know that individuals who have never experienced obesity or overweight really deal with. We know that the body will go back to its traditional weight typically, because think about it, we could compare it to cancer, and that's your specialty, right? Like if someone comes in with a small lump in their breast and we, treat that, we're early in the disease process, versus someone comes in with both breasts with raging breast cancer and they've got something going in, some cancer going into their liver too. Now we go in with the drug because we need a more intensive therapy. So for someone who just needs to lose 5 or 10 pounds, the body most likely can regulate that and get it back to that weight. There may be reasons, of course, that it will be more difficult to do. Let's say you've gone through menopause. Let's say that you're at a different age in your life, right? You should not expect to be at your weight of age, when you were 18.
Right.
So there's something about expectations, and I think it gets into this weird space because weight is something that we talk about in a society in general, and then there's weight what we talk about in health, in healthcare, right? And so it's important for people to realize that these medications are to improve your health and to improve your functionality. So they're not meant to be a cosmetic. They're not meant to be just a little boost for 5 pounds off. This is meant to be a lifelong treatment.
Okay. All right. Now I'm going to ask you some of these questions I get now that are a little, and actually, you know what? It's not people's fault. It's kind of media, what it's showing. Now there's something called Ozempic face. And I just read something about Ozempic butt. Now, I'm one of the few brothers in the world. I've never had a butt. and I don't like squats.
I'm sorry to hear
but
that.
Anyway, so I already look like I got Ozempic butt. But anyway, what is, I mean, is that real? The way I always look at it, you're going to lose weight everywhere. So, people are saying now that it targets the face or targets the butt. Is that true?
That is not true. So I'm glad we're bringing this up because there is too much attention on this. When you and I have talked about so many positive aspects of these medications, improving heart health, kidney health, insulin sensitivity, your weight, we're getting focused on the wrong things, but let's talk about it so people know. Yes. Ozempic face, what does that mean? People can lose weight on these medications. And of course, if you lose weight in an unhealthy way, you are more prone to losing more muscle mass than fat mass. What does that mean? Your face has lots of facial muscles. You have lots of muscles in your neck. So when you lose weight, you're going to lose weight all places. Your body doesn't target usually one specific spot. Right. And as a result, if you lose weight very fast or you don't eat enough and nourish your body on these drugs, you could lose weight so fast that you'll lose muscle mass in your face. That is what is kind of the Ozempic face. Right. Now, of course, that shouldn't be happening. If you're under the supervision of a healthcare provider, right, that should not be happening because you should be losing weight at a safe rate. What does that mean? That means about 1 to 2 pounds a week on average, depending on the weight that you're starting at. And that also means that you need to be nourishing yourself. We as a society are like, if I don't eat, I'm going to lose weight. Yes, that's true, but that's for a short term until your body realizes you're in starvation mode, and then we got a problem.
Exactly. So I hope everyone was listening out there, even some of our medical colleagues, because all of this is interesting. Stems back to what you said before, is that us, still look at it as a choice, right? And we know now it is not a choice. Now, one of the questions I just received was, do I have to change my diet while I'm on these medications? Yes. So it's twofold. What I tell people, yes, you have to change it, but a lot of times it goes the opposite way. I've had a lot of patients, like our good friend, Cheryl Underwood. Hi, Cheryl. So Cheryl talks about it all the time, about her weight loss, and one of the things is that it becomes, some patients have to remember to eat. Some patients, have to remember to drink water. It does, it definitely reduces, some of the other cravings we're seeing. But what do you say about that?
Yeah, so I explain it to patients often as swinging the pendulum. So we went from a place of feeling uncontrolled with our eating. We're constantly thinking about eating. We're constantly thinking about food. That's not a healthy place. We want to help you. We put the drug on or the medication on, start this anti-obesity medication like Wegovy, and suddenly you start having reduced appetite, you start feeling more in control, but the pendulum can swing. And suddenly you're on the other side where you're getting too restricted. You're not eating, you're not hydrating. That's not healthy either. We need that sweet spot. So if you are on these medications and listening to this and not getting enough nourishment, meaning your protein, your carbohydrates, that are complex, meaning healthy carbohydrates, all your micronutrients, we need you to think about talking with your provider to see maybe you need a lower dose. Maybe you need to change medications because you should not eat on this drug is what I say.
Excellent. And so it's more than how you look. I think that's something, especially, where we live here in Los Angeles, work in Beverly Hills, that it's often, more people care about that, but it's about being healthy on the inside. Now, something that I'm kind of excited about, and I hope you don't poo-poo it, every pun I do has to be related to this.
I'm catching that vibe.
Yeah, right. But there's some data that this could help with preventing Alzheimer's. Is that correct?
Yeah, so there is more and more data showing, like I was mentioning, kind of with like the heart and then the kidneys, is that there may be some kind of anti-inflammatory component to this. And that's what's fascinating, because we could find that these drugs could be used in a whole different school of population. So yes, there is really preliminary information and actual clinical trials that are being done actively looking at this class of medication, GLP-1s, could they be helping with Alzheimer's?
Well, this has been fantastic. I want to do this again, and you can give us some tips that when you are pregnant, things like that you can do during the pregnancy, for instance, like how can our environments, we'll go into detail about the actual environment that we live in, which a lot of times we can't do anything about, but maybe there's some things that we can.
True.
As you guys see, Dr. Velazquez is awesome. Amanda's awesome. She is down to earth, but you guys should Google her. Okay. She is the real deal. And how can they reach you on social media, all these things?
Yep. So my social media account is Dr. Mamacita. You can find me on Instagram, and then of course look me up on Cedars-Sinai's website. So I'm over in Los Angeles at the Center for Weight Management and Metabolic Health. We have a comprehensive team. We take care of patients anywhere from surgery to those who just want to do anti-obesity medications, plus a healthy lifestyle. So we always have that foundation of a healthy lifestyle we can help with. So look us up. We're happy to help. Yeah. Thank you for having me, Zuri.
And once again, I do want to give a shout out to Cedars for being smart enough to steal you from another health system, which we're not going to talk about. But anyway, you guys, as we always say, we try to provide a little edutainment, meaning that we talk about these diseases and these issues, hopefully in a more palatable way. As I always say, you shouldn't die from fear. You shouldn't die from embarrassment, meaning that you have issues, whether it's living with obesity. What do we say now, Dr. Velazquez?
Yes.
Instead of saying obese people?
Yes. So we always want to talk about weight in a sensitive way. We know this is a topic that can be difficult for people. So, Zuri and I were just having this conversation the other day about when you talk about obesity or talk about overweight, we always want to use it in people first language. And what that means is an individual living with obesity or a person with obesity. We don't want to define an individual by their disease. Think about, like, for example, diabetes. We wouldn't want to say that diabetic patient. We would say that patient living with diabetes, because that person is not their disease.
Excellent. And so once again, you shouldn't die from fear, shouldn't die from embarrassment. Talk to your physician, and you guys share this with your family members. Okay, we're going to try to, I'm talking to my Instagram person. Can we save this? Are we saving this? Okay, so saving this, and it will be with Dr. Mamacita. It will be on my Instagram. And you guys, thank you so much. And I promise we're going to have her back. Thank you. And thank you, Cedars-Sinai. Thank you.
Thanks, Zuri. Bye-bye.
Bye-bye, everyone.